Thank you, Andrew. Also thanks to Gordon Hayworth, who's the LTA video analyst. He helped me put this audio-visual presentation together. My topic today is the general biomechanics and etiology of the upper limb in overhead athletes, but I've retitled it. It's now called The Magic of a Lively Arm. The videos you're going to watch are a group of world-class tennis players with a lively arm. That's a respectful term used by coaches and players in baseball, cricket and tennis to describe someone with precocious and easy power and performance. I surveyed a few tennis players and coaches on their thoughts of what makes a lively arm. Amelie Mauresmo, Jonas Bjorkman, Ivan Lendl, Tim Henman, Andy Murray and Mark Taylor. And they all said different things. But the commonality of their comments included, well, Mark, perhaps it's due to technique, or it has to do with physiology, or I think it's got to do with muscle fibre type. It might be talent, perhaps it's genetics, skill, flexibility, strength, it's also got to do with strength. The one thing they all agreed, though, was that you had to have oodles of confidence to stay loose, to go for it, to not muscle or push the ball, but to hit through it. If you choose to read the literature on overhead sports upper limb injuries, the focus is on the glenohumeral labral tears and defects, of posterior cuff impingements, of instability, coracoid impingements, golfers, elbow, tennis, elbow, wrist tendon, wrist ligament, wrist joint injuries. Let's face it, so much can go wrong. I can quote Juan Martín del Potro, an ex-US Open winner and somebody who, if you read the sports pages, you'll know has had an ongoing issue with his wrist. He gave an interview just recently, actually, to the New York Times, and this is what he said. I won't do the Argentinian accent. There is a lot of apprehension that the pain is going to come back. Even if it's not there, it's the fear that if I mishit or overhit, I'm going to end up with the same thing again. His doctor said in the same interview, when Juan prepared for a backhand, especially a topspin shot, he'd dip his left shoulder, his upper extremity would move down, and basically he'd hyperextend his wrist to come up and make contact with the ball. It was at that precise moment that he got the pain. And for the longest time, it was a challenge. First of all, to figure out what was going on, and then to fix it. But once the pain and the dysfunction had been resolved, Juan still had to find a way to get those oodles of confidence back so that he could go for it again. It's not easy. If I focus on one part of the upper limb, though, in this short presentation, the crazy thing is the glenohumeral joint. If you all remember back to your undergrad biomechanics lectures, we should only really have 2 or 3 millimeters of translation of the head of the humerus in relationship to its instantaneous axis of rotation in the glenoid, because if we have anything more than that, we'll be getting excessive load and impingement through those structures. So, with any athletes who throw, who serve, or who bowl, they need large ranges of external rotation to accelerate their arm for maximum power. So you've got increased ranges of movement, strange changes through the passive restraints at the glenohumeral joint, and at the same time a desire through the dynamic stabilizers to have this head of humerus not moving more than 2 or 3 millimeters throughout all of these actions, repeated again and again and again. Let's face it, it's a miracle that these elite athletes can perform the way they do. And the thing that constantly amuses me, it's even more of a miracle that those 60-year-old club tennis players with the awkward service action, the osteophyte-ridden subacromial space, can play their mixed doubles every Saturday morning of the summer without doubting themselves. It's crazy. And let's not forget, there's technology to consider as well. And it's always changing. Racket frame dimensions, composition of Kevlar, carbon fibre, graphene, The string type. Does the player that you're evaluating use gut or synthetic or a combination of the two? Their string tensions, the string pattern, the ball type, the court surface. Is it clay, hard or grass? Even their footwear. Have they changed that? Does that have an effect on how they're moving and therefore how they're engaging with the ball? And how does the player interface with the racket? How do they grip the racket? How do they squeeze it? As you continue to watch these videos play, I hope you recognise the variety and often, with these world-class players, the suboptimal mechanics of these guys. You know, if we are clinicians involved in a team looking after somebody like this, do you get involved? Do you say, hey Francis, I know you can smash a first serve at 125 to 140 miles an hour, but you've got to improve your thoracic extension. Or you might get some secondary posterior cuff impingement. Or do you just go, wow? Do you just go, wow, and leave them to it? Well, I have to share with you that after a couple of decades of clinical wisdom, working with some of the world's best tennis players, you just say, wow. That's all you can do. But the thing to do is, as working in a team, you can get his strength conditioning coach to work on his calf strength, seated calf raises, calf press, skipping. He can work on his explosive power of his lower limb, doing deadlifts, box jumps. His core shouldn't be rigid, he shouldn't be planking and bracing, but he should be body aware, supple enough to attenuate the rotatory forces of acceleration and deceleration in his sport, and hope that his surreal speed on serve and ground strokes continue to be predicated on his God's gift of athleticism that allows his upper limb to be whip-like and loose as a goose. That's the point I make. The 60-year-old mixed doubles player and Nick Kyrgios are both just lost in competition. They're smashing that ball and winning points, games, sets and matches. They're bold and fearless in going for it. Any observations we have, any interventions we may offer, and I believe any comments we may make must always take that into the highest consideration. There's magic in the bodies and minds of overhead athletes. We need to acknowledge and respect that. It's not all about randomised, double-blind clinical trials that should shape our clinical observations and engagement. There's art that sits alongside the science. There's magic to be appreciated.
Over the past 20 years or so, I've spent a lot of time thinking about the biceps tendon, and I've come to the conclusion that it is quite probably the most interesting muscle around the shoulder girdle, if not the entire body. And there are several reasons for this. Firstly, unquestionably, the biceps is the most famous muscle in the body. From the age of 5 upwards, everybody knows where their biceps are. Also, we use the biceps muscle to communicate with each other. We use it to demonstrate power, to intimidate or show strength to our opponent. And some people also use it to increase their sexual attractiveness. But there is also an anatomical reason why the biceps is so interesting. Firstly, it has 2 origins, but one of them is intra-articular, and it is the only muscle in the body that does this. But this was not always the case. If you believe in evolution, we all started as quadrupeds, and the biceps tendon in a quadruped is a powerful flexor that drives that forelimb forward. And if we look at the skeleton of a horse more closely at that articulation, the biceps tendon comes from the supraglenoid tubercle and down the front, attaching onto the radius. If we look at the scapula is elongated, a rather small glenoid, and the coronoid process lies just above it. If we compare that now to the human scapula, the glenoid is bigger, but look at what's happened to that coracoid. It's gone from a mere nubbin of bone to this majestic protuberance that thrusts forward flirtatiously to give the attachment, of course, to the short head of biceps. So how did we get from there to there? Well, if you again believe in evolution, as we stood up, the rib cage flattened, the scapulae moved outwards, and in fact the infraspinous fossa of our scapulae are far greater, allowing us to externally rotate our arm so that we could climb through trees and start to throw. Now chimpanzees can throw, but not as effectively as us. And if we go back to the skeleton, what you notice is that the chimpanzee or the primate skeleton is tilted forward, so they simply don't get that clearance. Once we evolved as humans, we are now able to clear under the acromion to throw. And we use these skills to initially start throwing rocks and spears to hunt our prey, and subsequently to be able to throw a spear at some distance and speed. So you see, the dominance of the human race over the entire animal kingdom is actually down to the shoulder joint. Now, when I talk about the glenoid labrum to my patients, I describe it as looking and having the consistency of a calamari ring. Here it is in a cadaveric section and in intra-articular arthroscopy photographs. But the glenoid is a complex structure. It has a number of functions. It increases the glenoid depth, it prevents translation of the humeral head, and it stabilizes the biceps tendon. And in fact, it has very discrete layers. It has an inner core, an outer core, and a superficial mesh on top. This study looks at the nerve endings inside within the glenoid labrum, and there are both type 1 and type 2 that can respond and activate to both slow and sudden stimuli. So therefore, the labrum is a living organ that has a role in proprioception of the joint. The biceps tendon, of course, attaches to the labrum, some going in front, some people have predominantly anterior insertions, but it contributes to that whole mechanism. So how does it go wrong? Well, there are two ways you can get injuries to the superior labrum. There is the single traumatic injury, such as falling on the outstretched arm, then repeated overhead activities, such as with throwing, tennis serves, butterfly stroke in swimming and canoeing. The overhead throw has several recognized stages, from wind-up to follow-through. And one study looked at the activation of the biceps muscle during these different phases. And if we look at that, we can see the biceps is in fact active throughout this cycle, but particularly in the abduction and externally rotated position or arm cocking. Tennis serve has a similar cycle of movements. So what happens when the arm is in that abducted, externally rotated position is very interesting. The biceps tendon becomes elongated and also twists, putting a great deal of stress at that supraglenoid tubercle. Now, these guys practice this throw time and time again, and it is well recognized that with repeated microtrauma to the posterior aspect of the capsule, it becomes inflamed, it fibroses, it tightens and contracts. And what happens with this is that instead of the humeral head remaining centered on the glenoid, it shifts upwards, therefore again putting stress on that superior labrum. So how do these patients present? Well, as is so often the case, it's the history. They will give you the history. Listen to your patient. They complain of pain, and it's a sort of deep, aching, diffuse type of pain, often related to the activity. There may be clicking in the joint, and with the older patient, look out for signs of bursitis, because that often occurs as a result of repetitive microtrauma. When you're examining the patient, do a full assessment, but particularly for the biceps tendon, bring the arm into that vulnerable position and then either resist supination or ask them to perform a biceps contraction, and this often elicits pain. I prefer this one, which is the O'Brien's. Bring the arms perhaps slightly more across the body than it's shown in this picture and resist elevation. That's a lovely test for the biceps tendon. Coming on to investigations, Monica is going to be talking to us in much more detail, but I prefer the MR arthrogram. And what I'm looking for is that little track of dye which goes up here into the upper aspect of the labrum. Now, as orthopedic surgeons, we like to classify things, and the slap lesion is no different. There's a type 1 where there's a little bit of fraying, type 2 when there's a detachment, and type 3 when there's a sort of bucket handle tear, it's meniscus type lesion that drops into the joint, and type 4 is when it extends into the biceps tendon. For type 3 and type 4, surgically, you would resect the unstable labrum and perhaps perform a tenotomy. The real debate that occurs in shoulder surgery circles is what to do with the type 2 lesion. Well, we have 4 options, and I presented this once at a European meeting, which will explain the next few slides. Firstly, we can take the Italian approach and ignore the problem. Cosa problema? Secondly, we could take a British approach, be terribly polite and just debride the tendon. Option 3 is be German, very efficient, and fix it and repair it. Or type 4, do it the French way, which is cut its head off and tenotomize it. The French are such fans of cutting the biceps tendon, they proudly call themselves the biceps killers. But we were thinking, well, what is the effect of not having a biceps tendon? What does the biceps tendon do? And we conducted a series of experiments where we loaded the tendon to see how much the humeral head would move, and then cut the tendon to see how much it would move. And what we found is that there was an increased rate of translation, particularly at 30 degrees of abduction, where the humeral head was going forward. Now imagine the effects of that on somebody who's throwing regularly for their profession. My preference, therefore, is to fix it. And there are a number of anchors now available on the market. There are metal anchors, biodegradable anchors, plastic anchors, suture anchors. There's also very different techniques that you can do. You can either have a single anchor with a simple suture, a single anchor with double-loaded sutures. You can have 2 anchors, 2 sutures. You can have 3 anchors, 3 sutures. You can have 2 sutures with a mattress. I feel like I'm at a rave. But to be honest, the point is, it doesn't really matter too much, as long as the principles are the same. Lift the labrum, debride the upper part of that glenoid, and fix it down. The key take-home message, if surgically, is don't strangle the biceps tendon. In the words of President Trump, that would be really bad news, people. Don't do it. You can do it also by placing a single anchor with 2 sand, and that, again, squeezes down the biceps tendon. My preferred technique is to use a suture anchor, which is 1.7 millimeters big, so it's small, and to put 1 in front and 1 behind, and then I can extend if I need to. Post-operatively, I keep my patients in a sling for 4 weeks. Shoulder shrugs, thoracic rotations, hand, wrist, and elbow. I hate the pendulum exercises. I don't really like that for these patients. 5 to 8 weeks, start increasing that range of movement, but no active bicep strengthening at this stage. And then final stage is increase the strength, put them back into their functional activities, and start to challenge proprioception. Does it work? Well, there are plenty of studies that would support that it does. Shoulder scores go up, pain scores go down. But what about the professional athlete? Well, this study looked at professional baseball players, 24 players, and of that group, 60%, or just over 60% returned to play. And of the ones that did go back to play, 86% were able to go back to their previous performance. So it's okay. What about those who are over 35? Well, in this study, they showed that if you do a tenodesis rather than a repair, you have a shorter recovery, more predictable outcome, and a high rate of satisfaction and return to activity. So this is information we need to tell our patients when they're choosing what surgery to have. I couldn't do this talk without presenting this study, which came out this year, and this was a great study, which looked at 3 groups of patients with a type 2 SLAP. One group had a labral repair, one group had biceps tenodesis, and the other group had sham surgery, which meant they just cut the skin, put the scope in, had a look around, and pulled out. And they found no difference between the 3 groups. Therapists love this study because they get to say therapy is better than surgery. But having seen this, I would still say if a patient presents to me in clinic, I would initially offer them rehab because, let's face it, most shoulder problems would get better if you just stood up properly. I would consider injecting the subacromial splice to see if the bursitis is causing the pain rather than the SLAP lesion, and then offer them more rehab. If this fails, I would offer them surgery. My preference is to repair it. If there's any damage to the tendon, I would do a tenotomy or tenodesis. I think one of the most important things I've learned as a surgeon is that I have to listen to my patients. Every patient has different needs and expectations. One size doesn't fit all. My role is to discuss all different options with the patient and come to a decision with the patient, but with the coaches, the trainers, the sports physicians, the physiotherapists, and the radiologists. And what I say to my trainees, in the words of my all-time favorite diva, is that you must think before you cut that tendon. Thank you.
Okay, so I'm going to run through the radiology of impingement and SLAP. So I'm going to start with external impingement, and this can be divided into primary subacromial, where you have abnormalities of the actual coracoacromial arch, or secondary subacromial impingement, which Susan touched upon, where you have glenohumeral microinstability, but with a normal acromial morphology, but they develop secondary bursitis. And on the other side of things, you have internal impingement, which is primarily seen in your throwing athletes. And this can be divided into the classical posterior superior impingement in that overhead throwing athlete in that ABA late cocking phase, and then anterior superior impingement, which is perhaps seen less often in the overhead throwing athlete in the follow-through phase. So we will run through these. So in external impingement, we are, as radiologists, looking at the coracoacromial arch, which involves the anterior third of the acromion, coracoacromial ligament, and the coracoid process. And we look at the imaging features of that, which may include a mechanical abnormalities such as an acromial spur, osacromiale, which is important in these young throwing athletes, or AC joint osteophyte formation, which then leads to subacromial bursitis and tendinopathy. So we will typically begin with radiographic assessment, which I think is very important, and we're looking at the bones here. So we're looking for acromial spurs. This is best seen on the 30-degree caudal tilt view. This is a patient who had bilateral symptoms of external impingement. So we did these x-rays, and you can see those acromial spurs, which may be leading to impingement. Osacromiales. So it is traditionally believed to contribute to subacromial impingement, and it's therefore quite important to identify in these young throwing athletes. Quite difficult to see on the frontal view, so the axial view is very important. And there you see the acromial physis. It can be present, however, in patients up to the 25 years of age, and as such really should be viewed with caution as a cause for impingement in young athletes. They can get abnormalities here because you can form a pseudoarthrosis, so you can get osteophyte formation at this site, which starts to cause impingement, and also you can get deltoid contraction, which pulls on that osacromiale, which further can lead to impingement. So it's quite important to pick up. This is a very typical finding of what we might see, a bit of greater tuberosity sclerosis, quite commonly seen, typically with insertional supraspinatus tendinopathy. We see that quite a lot with external impingement. But really, ultrasound is the key imaging modality, I feel, for this. We can assess the bursa and the rotator cuff. So what do we look for on the bursa with ultrasound? We look for subacromial thickening. The bursa is thickened. You may get a small effusion in the bursa, but in some patients, actually, it looks quite normal, and actually you give them an injection and it takes their symptoms away. You may see AC joint osteophyte formation on the ultrasound, which is a surrogate marker for inferior osteophyte formation, which may be causing impingement. But ultrasound really comes into its own because it's a dynamic modality. So you can actually get the patient abducting their shoulder, and then you can see this bunching of the bursa and ballotment of fluid from a subacromial position to the subdeltoid position. So you can see they've clearly got bursitis. You may get bunching of the bursa at the coracoacromial ligament, or you may get simple block to abduction. Following that, you can administer a ultrasound-guided steroid injection, so you can get direct needle placement, injecting steroid and local anaesthetic into the bursa. I use quite a high volume, about 10 mils, because I want it to spread across the whole of the bursa. And then, quite satisfyingly, the patient may have complete resolution of their pain. It's the Valentine-Ellis test. You can bring their arm up, and you think, fantastic, you've got a diagnosis and you've administered a therapeutic injection. But ultrasound also has fantastic spatial resolution. So we can look at the bursal for subtle signs such as bursal surface attrition, where you have this slight dipping in the superior cuff. You may get delamination, where you may get this hypoechoric cleft within the tendon. And that can be beautifully seen actually on ultrasound. So the advantages are it's very inexpensive, it's very easily accessible, very well tolerated by patients. I think patients quite enjoy it because they can see the inside of their shoulder, and you can administer an injection at the same time. It is, however, operator dependent, can be technically challenging in some cases, and it doesn't give you a lot of information about the underlying bone and certainly the labral pathology. So moving on to internal impingement syndromes, and we've heard a bit about this. So posterior superior impingement and much less commonly anterior superior impingement. So we've heard about that ABA position, and so what happens is you have that contact of the undersurface of the posterior superior rotator cuff with the posterior superior labrum and in the ABA position, and you get pinching. So you get these classical partial articular surface tears at the junction of the posterior fibers of supraspinatus and infraspinatus, and you also get that classical slap tear. We've heard that it happens in these throwing athletes in lots of these different sports. So what do we see as radiologists? Now you may see this, which is called the Bennett lesion, and Susan spoke about the posterior capsule becoming thickened, it can become slightly mineralized, and you may see a subtle exostosis at the posterior inferior glenoid. I don't see this often, but it is one of the signs described for posterior superior impingement, because you get that posterior superior shift of the humeral head. But this should be really imaged with an MRI or MR arthrography. You can't do any real assessment with ultrasound for this. And you classically get that partial articular surface tear, which is beautifully seen on MR arthrography, and then you get the slap tears. You get a combination of subcortical humeral head cyst formation where the impingement is occurring, and then you can get thickening of that posterior capsule. And this is the constellation of symptoms you see with posterior superior impingement. And this is what you sort of get, subcortical head cyst formation. Now, as radiologists, we actually see this quite a lot, where the infraspinatus tendon inserts. So we can't be overcallers of this. I think I tend to describe it more with the full constellation of symptoms and if it's the patient's symptoms. But otherwise, you do typically see cysts there, and that represents vascularity. And then the superior labral tear. So typically, as Susan described, this calamari looks low signal on all sequences on MR imaging. If you see high signal within it, then you've got to be considering a slap tear. The type 1 slap tears are very common, particularly in the elderly individuals, and it may be asymptomatic. And it happens because of this peel-back mechanism that was described, where you get torsion of that biceps tendon, and it classically happens at the biceps labral anchor extending posteriorly to about the 11 o'clock position. So anything that causes, this is an example of gadolinium extending into the superior labrum. It's got an irregular contour consistent with the slap type 2 tear. This is another example. This is not an actual MR arthrogram, but it can be picked up on just conventional MRI. This is another type 2 slap tear. You can actually see a small paralabral cyst formation with it as well, and it's in the typical classical position for posterior superior impingement. Now, slap tears, there's many subtypes, and I don't go into all of the subtypes. I probably report by describing the tear rather than the different subtypes. I can't remember them all, but the top 4 are these. And I think it's important really to describe if it involves adjacent structures such as the biceps tendon. And as Susan mentioned, she likes MR arthrography for these, and it is slightly better than conventional MRI for picking it up. So if your conventional MRI is normal, I would move quickly onto an MR arthrography if you feel that the patient has symptoms of a slap tear. But very important to remember our normal variants. And the classical normal variant at this site is the sublabral recess, and it's between the biceps labral complex and the glenoid. It has a typically smooth outline, and it moves in a supromedial direction, not a supralateral direction, as opposed to the slap tear, which has an irregular contour and moves in a different direction. The other normal variant to remember is the sublabral foramen between the 1 o'clock and 3 o'clock position. I'm going to go on to anterior superior impingement, and this is typically through the follow-through phase. I see this probably less commonly, and it is where you get friction damage at the undersurface of the biceps pulley system as it impinges on the anterior superior glenoid above the horizontal phase of internal rotation and adduction. And so you might see biceps instability, and that may be secondary to tearing of the coracohumeral or superior glenohumeral ligaments. As radiologists, we may see subtly the biceps medialized within the bicipital groove or perched or dislocated on the lesser tuberosity. And these are associated with articular surface tears of the subscapularis and supraspinatus, as well as anterior superior labral disease. So on ultrasound, I think it's a very good modality for looking for biceps instability. Perhaps that biceps is slightly medialized within the bicipital groove. It's still sitting in the bicipital groove, but you can dynamically externally rotate their shoulders to see if it moves. Again, you can see that on MRI. This is another example where the biceps is actually perched on the lesser tuberosity, quite important to pick up. And this is an example of dynamically looking at it. So we're just following the biceps tendon down here. And this is associated with a focal subscapularis tendon tear, which I think we'll come to as we move up. I'm just going to move further up. But you can actually see the biceps tendon perched on the lesser tuberosity there, and it's sitting right on the lesser tuberosity, and you can see the subscapularis tendon tear. So that's quite important and nicely picked up on ultrasound. MRA is better for looking at the subtle pulley injuries. This is an example of a subtle superior glenohumeral ligament tear, which is associated with these biceps instability and anterior superior impingement. And this patient also has a subtle articular surface tear of the subscapularis tendon. I know I've gone slightly over time, but I just want to touch upon CT arthrograms. I really reserve this mainly for post-operative cases because it's in CT, you can really employ fantastic metal artifact software, reduction software, so you can really look at the labrum and you can see the cartilage abnormalities on CT, CT arthrograms, as opposed to the MR arthrogram we have here, where you have blooming artifact. So I think CT arthrogram does have its place, certainly in post-operative cases. You have excellent definition of articular cartilage. You can see intra-articular bodies. Very good for bony anatomy, particularly in your osseous Bankart lesions. And you may see the Bennett lesion where you say subtle mineralization within that posterior capsule. It's also quick and actually better tolerated by patients. Of course, the disadvantages are the ionizing radiation and suboptimal assessment of the rotator cuff and reduced soft tissue contrast. So in summary, external impingement, I think radiographs initially can be useful, followed by ultrasound and injection. Internal impingement, I think you need to move to an MRI or MRA. And anterior superior impingement, where you're looking for biceps instability, I think ultrasound's very useful. And CT arthrograms I reserve for generally post-operative cases.
As Mr. Wallace said at the beginning of this session, this is the most important session on the meeting because it's on the shoulder and elbow, but this talk is the most important one because it's based on the elbow, which is the most important joint in the body nowadays. So can I get the slides, please?
You should be able to just click forward.
Oh, okay. Perfect, thanks.
And then again, yeah.
Perfect. So I'm going to focus on a pathology that we see quite commonly, not only in high-level athletes, but in sports people. What is called the valgus tension overload syndrome. I'm going to try to teach you or to explain my view on this pathology. We see this mainly in Spain, not in baseball players, but we see in handball, which is pretty strong in Spain, also tennis, and very rarely in basketball, but we may see it, and occasionally in judo guys. This was described in 1983 in the U.S. in baseball pitchers in 5 patients, and these surgeons recognized that some of these pitchers had some osteophytes in the back of their elbows that they were causing pain with full extension on the elbow. So these patients come to my clinic, to their clinic, with pain in the cocking and acceleration phase and deceleration phase. So when they have the valgus movement in the elbow and they fully extend the elbow, they have pain, in the back of the elbow. This pain may have also some crepitus, some locking, if it is very advanced, because they develop loose bodies occasionally. And because they have pain and extension, they develop synovitis in the back of the elbow, and occasionally that you will see in the clinical exam that they are not able to extend the elbow fully. This was many years ago described in a very old paper that was not very renowned after the Andrews paper, but in this paper they mentioned that this problem was caused by a slight laxity of the joint, causing the posterior olecranon touching the posterior part of the trochlea of the elbow. This hitting initially causes only pain because of the cartilage injury and edema, but then if it follows, it becomes osteophytes, etc. And this is the pathomechanics of this syndrome. The elbow fully extends in valgus, and there is some hitting of the posterior olecranon on the posterior part of the trochlea here. And with time, that develops osteophytes in the olecranon and also sometimes osteophytes in the back of the humerus. The most important message of this talk is that this may happen with or without injury of the medial collateral ligament, and is key to detect if the patient has medial instability or not. You may be lax without instability, and if you're lax and your olecranon hits the posterior trochlea, the ligament is okay, it's just laxity. But if that laxity becomes instability medially and you don't do anything on the ligament, then you may remove the bone, as I will show you in a minute, but the instability will continue and the problem will not be solved. So the message is, whenever you think your patient has this problem, always test the medial collateral ligament before you make a final decision. Because if you remove the ligament, if you remove the bone and the ligament is injured, of course, there will continue to have problems, even bigger problems than before, because you have more space in the posterior olecranon to hit. This has been very well studied, and it has also been demonstrated that, as I said before, laxity can cause osteophytes. So if you get pitchers, tennis players, handball players, asymptomatic, in whom you can explore the elbow and show laxity, many of them will have osteophytes that are not symptomatic. So this problem is indeed related to laxity and obviously to instability. So do not forget the ulnar collateral ligament when dealing with this patient. This is an MRI of a patient that had this problem without osteophytes, but he had a hitting of the olecranon into the trochlea and had some cartilage problem and edema, and this patient had a medial collateral ligament insufficiency without an osteophyte. So that was the beginning of the problem. If you don't solve the medial collateral ligament problem, this patient will develop the posterior impingement syndrome. How do you clinically, you can imagine, it's pretty easy to think about it. And then there are several x-rays that you can take. This x-ray with the elbow slightly in external rotation allows a better view of the olecranon medially, where the osteophyte always is present. Normal x-rays will show occasionally bone which is separated from the olecranon, sometimes is attached to the olecranon, sometimes it looks like a fracture, and sometimes you will see in the back of the trochlea some reactive bone formation as well. Obviously, CT scan gives you absolutely the diagnosis with a 3D dimension. It's a nice view of the osteophytes. This is a very well advanced case, but in early stages, like this one here, this is a young guy playing baseball. Sorry, it's basketball, not baseball. He has an injury in the posterior olecranon. It's very well seen in the three-dimensional CT scan, and he had problems and requiring surgery. If you don't see an osteophyte in the x-ray or the CT scan, in my practice, I always ask for an MRI. The reason being that, as I said before, many of these patients, before they develop the osteophyte, they have problems in the posterior trochlea or the posterior medial olecranon. So if you see edema, if you see loss of cartilage there, and you suspect that the patient has that problem, then you should ask for an MRI and find out if the problem is that the elbow is going into valgus extension overload. So how do we treat this? Once we make the diagnosis, obviously we go for a conservative treatment period. I like to inject those elbows with a big amount of anesthetic and a small amount of steroids. And the reason for that is because it gives me the diagnosis. So if the patient is under anesthesia locally, and then you extend fully the elbow and the pain is relieved, then you are sure that the problem the patient has is posterior impingement. We send them to the physiotherapist, just trying to improve the proprioception of the elbow, improving the throwing mechanism, etc. If they do not get better by 3 months or 4 months, and obviously if they are high-level athletes, you need to go for an operation, because these patients need to go back to the practice. The operation may be very simple or may be very difficult, depends. So the main thing you need to do is remove the osteophyte and you do with the scope, arthroscopy. You can do that with a simple burr, as you see here, or you can use an osteotome. But you need to make sure that you remove exactly what is hitting the posterior trochlea. So this is a case where there was an olecranon osteophyte that was removed, and you see that this is very small. Sometimes the osteophyte that you see seems, I mean, this is nothing, you know, but we're talking about very high demand patients. In myself, that would not be a problem. But if I am throwing like 60 or 70 times every hour, that becomes a problem. Even small osteophytes become a problem. So in my experience, I committed several mistakes at the beginning. I was very conservative removing bone because I thought, wow, this is going to be a problem. And I had several times to, not several, but a couple of times to reoperate the patient because the amount of bone I removed initially with the scope was not enough. And I can remember of 2 of them. And then once I went back and removed more bone, they got better. And then you need to understand where the osteophyte is, whether it is posterior, whether it is posterior medial, or whether it's just a small piece of bone that is detached from the olecranon, because maybe a fracture of the osteophyte. And then I would, especially talking about athletes, I would encourage you to ask for a CT scan once the operation is done, because they need to know that the bone is removed. Even though they trust you, they trust images. And if you show this image to them, they will get better. Do not remove too much bone because the olecranon is part of the elbow stability. So try to keep, if you remove more than 9 millimeters of olecranon, then the medial collateral ligament raises the strain quite a bit. And you may, and especially if the patient is unstable, you may run into problems. So remember, always check the medial collateral ligament before you do anything on this patient. This is the test that was described in the Mayo Clinic several years ago. I was a fellow of the describer, that's me, like 20 years ago, as you can see, which is the VALGUS moving test, which is the more sensitive and specific for detecting medial collateral ligament problems. And if the medial collateral ligament is injured or is deficient, you need to reconstruct that. You can elect whatever technique you want to do, but you should not do just bone removal without ligament repair. If there is damage to the cartilage, you can also work that in the early stages by chondroplasty or microfracture. That would be effective. And the outcomes in the literature are pretty good if the diagnosis is made both in adults and in adolescents. So as a conclusion, bear this in your mind when you're treating athletes with elbow pain. Remember to rule out always instability, and arthroscopy is a useful tool. Thank you very much.
Hello everybody, and welcome to the grand finale of the upper limb session today. I'm going to talk to you about tennis wrist, the ulnar corner. And the first question you might be asking yourself is, what is the ulnar corner? What do I mean by that? And basically, what I'm going to talk about is this area here, around the ulnar styloid, which forms the apex of a sort of triangle here, which includes 2 very key structures, the ECU tendon and the triangular fibrocartilage complex. And the reason these are of interest is because they are very prone to injury and in tennis players, and can be very detrimental to people's careers in that aspect. In this coronal view, you can see that the 2 structures are quite intimately associated in this formation of this area here on the ulnar side of the wrist, which is key to the regulation of the movement and the support of the ulnar wrist. To understand why they become problematic in tennis players, it's important to understand the anatomy. And of the 2, probably ECU is the most significant problem. And this is a muscle that arises from the lateral epicondyle of the elbow. It runs down the lateral side of the forearm, medial side of the forearm, and it goes down into the base of the 5th metacarpal, where it inserts here. And it functions synergistically with other muscles, but basically it can extend the wrist and ulnar deviate it, and it's important for maintaining power grip. key to the issues that it suffers is the fact that in the distal area here, it runs through a subsheath which fixes it to the dorsal part of the ulna, and it forms what's called a fibro-osseous tunnel. There's a groove in the ulna and some sheath underneath the extensor retinaculum that holds it in place, and it's reinforced on the medial side by the actual extensor retinaculum coming in, which is the linea jugata. And this is what it looks like in vivo. It's a tunnel that, when you open the retinaculum, you can see there's a sort of pulley around the tendon there. And it's important because it stabilizes the tendon during forearm rotation, so that, unlike the other tendons, ECU is fixed in position when you go from pronation to supination. And when you go into supination, it has to go round a pulley here, which is exacerbated if you supinate and flex the wrist. And this is precisely what high-level tennis players and ordinary-level tennis players do, particularly with the double-handed backhand. And you can see here with Djokovic has got the wrist. He's going into supination, it's flexed and it's ulnar deviated, and that little tendon is going right round a pulley there. It's been made more of a problem because there's an increasing tendency for topspin and whipping the wrist around, and in using more extreme grips. Again, here you can see it very clearly that the muscle is working very hard and that tendon is going round a sharp corner. So what happens that causes the problems people get is that over time you probably get micro tears in either the subsheath or the tendon, and then you can get tendinitis and inflammation, and that can be over time progressive to become a slightly different condition called tendinosis or tendinopathy, where the tendon fails to be able to respond to that injury and starts to actually change its integrity. It can go through stages: reactive tendinopathy, disrepair, and eventually degenerative tendinopathy, which can actually cause the tendon to become somewhat weaker and less robust. There are reports of it rupturing completely. These are very rare, and these sort of form case reports, probably caused just by a sudden force in the wrong place. Could be associated with tendinosis and steroid, but the cases are so rare and difficult to diagnose, it's probably difficult to actually draw that conclusion. And the diagnosis itself can be difficult because actually the presentation can be similar to tendinitis and tenosynovitis. The wrist can still function, but in a slightly different way. But the other key thing that happens that is of interest in tennis players is the instability that occurs due to this sheath. And there are three main types, and they are important to differentiate, because in type A, you can see the tendon has popped out of the subsheath. As it goes round into supination, it's popped around the end of the styloid process of the ulna. But if you popped it back in, put your wrist in pronation, it will sit quite nicely inside the subsheath again. If you have type B, where the radial side of the subsheath has come off, it pops around there, and if you slip it back in pronation, it's going to sit on top of the sheath. So if you simply hold it like that and don't go in and intervene, then obviously one is going to be concerned about whether that's going to be a robust treatment that's going to hold. And the type C problem that occurs is that the whole sheath can pull off and become like a sort of a saggy pouch within which the tendon can slip round backwards and forwards. And again, you would be concerned about treating that non-operatively, because although you could relocate the tendon, it's difficult to know whether you could robustly fix that sheath. So how do these cases present? Well, they're all fairly similar, actually. They tend to present with ulnar-sided wrist pain and a difficulty playing. Acute tendinitis usually presents in such a way that people have to stop playing for a period of time. You do get the symptoms of swelling and tenderness to palpation, but they're often quite subtle. Similarly, tendinopathy is similar symptoms, perhaps a bit more gradual onset. If you go directly to it, a slightly more vague location, sometimes described as a dull ache with a searing pain when you do certain moves. Some of these players can continue to play with tendinosis, and they find the first strokes painful, but then they can actually, when they get going, it's not so bad. Again, similar signs. And instability also presents with a similar symptoms and signs, ulnar-sided wrist pain. You may experience an acute snap or pop, but not always. The player normally needs to stop playing for a period of time, which is variable. Some can find they can go back to playing, but with a flatter action. They can't do the topspin, they can't do the strokes they were doing before, and the problem recurs on going back to that style of tennis. People have seen this before, but it's quite a nice demonstration. As the wrist moves from pronation to supination, you can just see the tendon there slipping out over the ulnar styloid process. And this goes to show that in some cases it can become chronic, and it actually can become painless. And so people can do this as a sort of party trick if they want to. You can investigate it. It's mainly a clinical diagnosis, I would say. Imaging is useful, but it's not 100% accurate, but it's certainly a very useful adjunct to try and establish. And you can do MRI scans particularly, and ultrasounds, which can also be done dynamically. Moving on to the treatment, well, for any tendinitis, we all know the treatments. You can rest, but no sports player is going to be keen on doing that for very long. You can enhance that with some splintage. You can, if it's mild, you can modify the technique. You can try and produce less stress on the tendon by using a different technique. You can change your racket strings, you can change your racket weight, you can do many other things. You can use steroid injections in the short term to settle the inflammation down and then look at modifying things. For instability, obviously, it's a different ball game, and you can treat that non-operatively, but I would say one is always worried. I would always be concerned about the longevity of that. But if treated non-operatively, you can go in a long arm cast impronation to reduce the tendon, and then you can need to use imaging, obviously, to make sure that the tendon is reduced, and you'd need to stay in something along those lines for about 6 weeks, and then have rehabilitation after that, which would be a disaster if it didn't actually fix the problem because it hadn't gone back into the sheath properly, which is always the sort of worry. So the other option is to operate, which I have a low threshold for doing, and you can then form a new sheath for the tendon to go in. You still have to immobilize it for 6 weeks and then rehabilitate. And you can see here, you can find the tendon, you can make, this is a non-anatomic repair using a little bit of tissue or retinaculum that's there, and you can put it back at where it's meant to be, and you can use this as a nice little flap to sort of put it back in a sleeve so that it can then sit and become robust over a period of weeks in a plaster. You could also, if you have the facility, if you have the tissues there, you can repair it anatomically, and these are some pictures of one that's been done where the sheath has been reattached to the ulnar with some little Mitec anchors along the bottom there. Rupture, it's very rare, but we would deal with that, but you can graft it with something like palmaris longus, as with any tendon rupture. Finally, I'm just going to very briefly touch on this because it's another big subject, and just going to very briefly say this is the triangular fibrocartilage complex, which is, as you can see, closely related to the ECU. It's formed of the radioulnar ligaments, the ulnocarpal ligaments, and there's a superficial and a deep portion. In a nutshell, things can go wrong with it as well. You can get it can tear. It can be a tiny tear. It can be a large tear. It can become inflamed and somewhat degenerate. And if you get a significant problem with it, you can get instability of the whole joint. And the way I would approach treating those are the opposite in a way to the ECU problem. Most TFCC problems will recover non-operatively with a sort of a combination of perhaps some steroids, some rest, some rehabilitation, some strengthening, some modification. So it's the minority of cases where you might feel inclined you had to go in and do something to treat a prolonged symptomatic tear that's not recovering with non-operative treatment. And as we know, these can either be done open going into the DRUJ or arthroscopically, depending on your preferred technique and on the particular tear in question. This, I'm just mentioning very briefly, this is, if you actually have instability of the distal radioulnar joint, you're going to have to do something quite significant to repair that, and there are many different ways of doing it. So finally, in conclusion, I was talking today about these two issues because they are significant problems on that side of the wrist. What I was going to say is it's useful to think about this. It is a big problem for many tennis players. So when you're developing, when players are developing their techniques, if you can develop a technique that uses the wrist in a neutral and robust manner, then you're probably going to have more longevity and less problems in your career, perhaps. But you can see when he hits it, he tends to use a one-handed backhand. His wrist is in neutral a lot of the way through, which is a much more protective kind of action. Thank you.
Any burning questions?
Hi, I'm Dan Fasher. I'm a musculoskeletal radiologist in Yorkshire. And as an ex-reasonable tennis player, now playing on a sort of veterans county circuit, I seem to attract other tennis players as patients. And I feel that we've got real challenges because the modern game is coaching people to use the so-called contemporary forehand, which lacks a follow-through and has an aggressive wrist snap at the end. And I just see tons of people who have continuous ulnar-sided pain. We put them through all of the imaging, so, you know, wrist arthrogram, conventional wrist MR, dynamic ultrasound, and in many of them, all I seem to find is capsulitis and synovitis in the ulnar carpal recess. So nothing to operate on, really, but they just have this recurrent problem after they play. How do you approach these, well, what I think are non-surgical patients with this continuous problem?
Yeah, I think it's very difficult, and that's what I was trying. One of the things I was trying to emphasize in the talk, and the modern techniques put so much stress on that side of the wrist that the athletes are so much fitter, they're so much stronger, the shots are so much faster that it is almost like it's just failing to cope. And as you say, that the thing you're describing is what I would describe as a TFCC, not a tear, but the sort of inflammation, delamination it's sometimes described. And there isn't a simple treatment for it. The slide I put up, I mean, you can inject a bit of steroid, that will usually settle the pain down temporarily, quite quickly. But then I think, it is a case of, if it comes back again, then really you do have to think about modifying the way you play if you can, because surgically there is almost nothing that we can do to stop that, other than you can go too far the other way and really stiffen the wrist and do something quite significant, but then they wouldn't be able to play so well. So I just agree with you. I think it's a very difficult problem, and I think other than rest exercises and technique to try to prevent the problem in the first place, we don't have an answer at the moment.
Maybe if I can, I'll come back to you in a moment. Mark, if we could maybe, in your talk you alluded to a whole raft of factors and variables in the modern tennis player that you can change or adapt. I mean, how would you approach that sort of a problem?
There's no way that competitive tennis players are going to all use single-handed backhands. It's a thing of beauty, but it's mainly a thing of the past. There's a consistency and a level of power that can be produced, and also disguise that can be produced with a double-handed backhand. That means that it will always, from now on, be the choice that you get taught as a junior and that you pursue through your career. Look, I mean, in competitive athletes in whatever sport it is, the also-rans break down. These people that you see that have the wrist pain aren't going to make it, that they won't get there. and it's just for a lofty few to come through that can cope with the brutal reality of the loads that need to be taken through one's career to get to winning slam titles and Davis Cups, and you have to realise that. So that's the first thing. When these people come in, it's just how it is. But what we all have to do is look well away from the area of symptoms if we think that we're going to have any opportunity or chance of reviving their competitiveness. And it's wrong and inappropriate to think that if somebody presents with a wrist pain, that if you do intervene locally with whatever that is, that you'll have any impact on them whatsoever. But if you go, as I alluded to, if you go way away from the area of symptoms, far down the kinetic chain to try to give them more robustness and resilience and dynamic power through their calf, through their trunk and pelvis, and an ability for them to learn the body awareness to attenuate that power, so that when they do have the contact on the ball, they're able to achieve that with all of that load coming from further down the chain and for a very relaxed grip, because you can still be in that position and you can still move through that range, but not with a big squeezing hold and with the sense that power is flowing through your arm rather than being generated locally.
Susan?
Well, I was just going to ask that gentleman, how important is it to be able to perform that stroke using that technique? Does it give you such a big advantage that...
Well, this is kind of one of the things that I was alluding to, is that I think that as medics treating these patients, we're at odds with what the coaches are teaching them, because it's very en vogue to use the contemporary forehand, which I perceive to be the root of most of the problems on the arm side of the wrist. And, you know, professional tennis players roll back 10 years did not use this technique. And I just think I've seen an explosion of arm-sided wrist pain with this technique. And I think that because I see it a lot in the young players who are just exclusively taught this method. And, you know, I'm keen to hear if other people who've been in the game longer have seen this change in pattern, and if therefore trying to sort of modify and move away from this in people who biomechanically can't handle that contemporary forehand is the way forward.
There's a comment from David Hargreaves.
Hello. In my previous life, I did a bit of tennis coaching as well, but I was never a good player, so I had to resort to becoming a surgeon. And it's interesting, though, because there is this new modality of juniors having to hit the ball as hard as they possibly can. But it's, again, very difficult for juniors to not want to copy their idolic stars, because they believe that if they are doing it that way, they will become the next Del Potro with a bad wrist. But I'm sure you're absolutely right. It's all to do with the topspin. And I think that if there are times when, if the wrist is becoming more painful, I encourage players to then go back and just playing flat again until it's settled down. And then they can go back to doing topspin, but trying to minimise it.
Mark, if I could just ask you, if a patient comes to you with an upper limb problem as a tennis player or a throwing athlete, which gives you more of a sinking feeling, the shoulder, the elbow, or the wrist?
I can't answer that. I get the sinking feeling quite regularly. I can't answer that, but it's all tricky. Just to come back to your point there, Dave, it's like, which I think is more important, is that the juniors, when they are learning to hit the ball as hard as they can these days, go through a graded softball program, and it's fantastic because what it allows them to do is to use their body to generate that load. So they can keep the ball in court and learn how to do a full body ground reaction force, letting go through the arm on all that contact. So I actually think that the contemporary way that kids are taught to hit the ball is great. I think that the coaches trying to get people to have the sorts of grips that they can have to hit through the ball is great as well. And I think that everything is about winning, everything is about performance. If sport is uncomfortable, the sport leads to lots of people having their dreams shattered. It's the reality. And you know, if you don't, you know, whether you're looking after somebody who's like wanting to get into an American college who has issues, or whether you're looking at somebody wanting to promote the longevity of their top 10 ranking in the world. It's the same traumatic conversations and issues that you have to deal with. And for a lot of people, you can't make it for them. It's their bodies, it's the way they do things. But I don't think that we should be saying, therefore, people shouldn't hit the ball like this, therefore we shouldn't use the modern technologies. It's carnage out there. And if you realise that and accept it, if you have those conversations with your patients who are players and are all about winning and ranking points and getting selected for US colleges and those kinds of programs, then they accept that. They've been dealing with that since day one. And you have to find a way forward. But if I just reiterate, that's from not looking at where the symptoms are. But it doesn't mean not doing a double-handed backhand. It means before it breaks down, before you have horrific damage, you need to have people who are experienced in this area giving realistic advice. Yes, the 6 weeks that you take off now is important. No, you shouldn't keep playing now with this pain. You must stop. Saying that before the degenerative change is the strong message you have to deliver at certain stages. But as I get at, once those changes have occurred, you can't do much about it. And there's going to be lots of disappointed people out there.
Alice?
Could you demonstrate the contemporary forearm for the benefit of all of us and me as well, to see exactly what you mean by that?
So we've got a racket.
Conventionally, the ball's coming into the net, you'd set your arm backwards with the elbow pointed towards it. You'd step in, and you'd hit through and upwards. Now, that's a very basic way of looking at it. The modern technique promotes that you place your chest forward, and you allow the arm to lag, and you snap the ball more, with your wrist coming over it, classically with semi-western or full western grip, over the ball a whole lot more, and then you finish, because of this arcing action, with a snap downwards across your body. And so you've got a much more open stance as you put your chest forward, lap your arm, and snap across. So so that places a lot more stress on the wrist than the wrist sort of ulnar position.
Well, if I can add to that, that was an okay presentation. But if I can add to that, the key issue through this whole thing is the take back. And what happens with the take back is that you actually have to have the racket way behind you, and you have to be in full pronation. And in that position, with the racket way behind you, pointing away, you're completely compromising and impinging down onto that ulnar part of the wrist. And then you're going from there to kind of like strike through the ball. And you still do move through. There's still a flow through. It's not like you're restricting it at all. But it's that change from full pronation in an extreme ulnar deviation to full supination as you're going through. That's what's creating most of that load. But if you're doing that with a soft, relaxed grip, and if you're doing that so all the energy is coming through your body, it's actually not that extreme. I mean, that's what I do. Yeah. Seriously, that's what I do, and I think you can do it with control, and you can do it being unconditioned, and you can do it fine. But you're not gripping the racket hard, and you're being aware and accepting the fact that the power is coming from your body.
Thank you. Maybe if I can address a question to Susan. Both you and Monica referred to posterior capsular tightness as a component of internal impingement. How do you sort of approach the management of that? If you identify that there is posterior capsular tightness in a throwing athlete or a tennis player, how do you go about dealing with that? What's the role of therapy, injection, surgery?
So one of the important clinical signs to look out for with posterior capsulitis is this sort of GERD phenomenon, where there's loss of glenohumeral internal rotation. The rotation arc shifts, so you get more of that external rotation. So those are the things to look out for. But in terms of what to do about it, I think in that case, absolutely physiotherapy is the right thing to do, working to perform capsular stretches. It's certainly not the first option to go in and perform surgery, and to work closely with the coaches and therapists. But a proper program of stretching. But again, what you mentioned is you start from the foot upwards, and don't just focus on the shoulder, because if they haven't got the stance right, this is going to be worse. And you can stretch it all you want, but you're not going to correct the problem on a long-term basis. I don't think.
And Monica, is there any role for hydrodilatation in this problem?
No, never. I love the hydrodilatation.
Yeah.
It's one of our most rewarding injections, but no, never done it for posterior capsular thickening. I mean, you can sometimes see it on MR. You get mild thickening of it. I mentioned the Bennett lesion, but no, we don't. I've never offered a hydrodilatation for that.
So, yeah.
Yeah, I have a question for Susan. In your talk, you mentioned that your preference in labral attachments, type 2, whatever it is fixation of the labrum. And I've done that many times in the past. And I had the sense, and I discontinued to do that because I had the sense that many of my patients, more specifically athletes, not necessarily professional, but amateurs, developed stiffness, and some of them had to discontinue their practice. So my question is, have you had problems, or maybe I was doing it wrong because you emphasized that you should not struggle labrum when you do it, but have you had in your practice the problem of stiffness, significant stiffness in slab 2 repairs after?
So a lot of patients that I see are probably the middle-aged athlete who plays a lot of tennis at the weekend and or trains a couple of times during the week. And in those cases, I give them the facts, and I discuss with him particularly that tightness can be a potential complication. But when I'm doing the repair, I don't take a big scoop of the tissue which contracts it. I sort of repair the labrum in situ. So it's just securing it rather than tightening it. I have had episodes where there has been post-operative stiffness. Sometimes patients go on to develop adhesive capsulitis post-surgery, and then refer to somebody like Monica to absolutely stretch out the capsule. But it can be a problem, but that's something you need to discuss with that I discuss with the patient beforehand. And I say to them, we can go ahead and do the superior labral repair. However, if this happens in the future, we may then need to do a tenodesis or a tenotomy at a later stage.
Graham.
Yeah, just on that, I think my experience has been similar to yours. And my threshold now is that a subpec biceps tenodesis is something that I'm doing increasingly, because I did have this sort of issue. It's a real pain, you know, if you fix someone's labral repair, they came back for the next 6 months, and there are always issues with sort of stiffness. So certainly, as athletes are getting older, I really have quite a low threshold. Maybe I'm becoming French, but I have a very low threshold to maybe not do too much actually in the glenohumeral joint, but really just to, and I find that subpec tenodesis for athletes is really great because you can always get the tension dead on. You take all of the biceps out because some of their pathology is going to be in the groove. So I've really moved towards that, and so I was doing a talk recently. I was looking at my logbook when I first came back about 15 years ago from the States. I was doing tons of labral repairs, but actually, as time's gone by, the number of labral repairs I'm actually doing is greatly decreased, but the number of tenodesis, maybe I think that's just my personal experience, but I do know if I'm going to do a slap tear that it's going to be quite a tough relationship with that patient for the next few months. They're going to be coming backwards and forwards.
But given what Mark mentioned about, you know, the tolerances of 2 or 3 millimeters in throwing or you know, serving, and what Susan described from the experimental work about the translations after sacrificing the biceps, what do you tell patients who want to get back to serving or throwing at pretty high county level tennis? You know, are you going to say to them, is that going to affect your decision about tenodesis or tenotomy? I mean,
sure. Well, I'll speak to them, but I'll have a sort of a realistic expectation. I think what I've realised more and more that is if you do dislocate your shoulder or have a labral repair of your shoulder or anything like that, in truth, you're never really going to ever be 100%, and I have to be honest with patients that, you know, we may be lucky and we'll get that, but you know, not to really necessarily expect that. So yes, I'm sort of aware of that, but I'm sort of saying to them, I'm not really sure that anything's really going to make it perfect, and then I'll perhaps discuss with them. But for tensioning the biceps, what I like to do is that I tend to actually expose where I'm going to do my subpec tenodesis, put a spinal needle into the tendon, and then I'll go and cut the tendon later on, so that actually I know that I'm going to fix it dead in the right place. But yeah, so it's difficult, and I think, in all honesty, I think, as we've really been saying, all these guys are at the elite level, And I think you're saying, basically the guys that really get to the top are probably the guys that have avoided injuries.
Self-selected.
And I think if anyone really is requiring surgery in reality, I think I've realised now that these injuries are probably, although people seem to do quite well, you see them down the line with further problems. That it's, basically having a shoulder operation for a sports injury may not cause you problems at the time, but I don't think your shoulder's ever going to be 100% perfect again.
Well, that was one of the things that I was going to say. A lot of the studies that look at slap repair versus tenodesis, looking at the sort of relatively short-term effects of it. But we don't know what happens over a 20, 30-year period, whether by cutting the biceps tendon you change the joint loading and point contact, and whether they're more likely or more prone to develop arthritic or degenerative problems. And that's also...
I completely accept that. And I think we see these guys who are 40 or 50 now who had the older stabilisations, and they've got really sort of bad arthritis. So I suppose people have got to live for today, and maybe we'll sort some problems out. But
tomorrow.
If I can come in there, I can tell you that pretty much all of those people, that if you snip off their long-headed biceps tendon, they're going to have absolutely dodgy shoulders. It's going to get worse and worse and worse. My point is, before you get to that level, most of the people who I see in their 50s and 60s and 70s consider themselves not to be an old person with a sore shoulder, but they consider themselves an athlete, a tennis player with a sore shoulder. And I think the one thing that they don't get ever told is that if they massively increase the amount of time in the treatment intervention that they have and the amount of time in the conditioning that they have, and that they start to get a lot stronger in their legs, in their butt, and they really, really work hard on their thoracic spine mobility, they don't need to get to that stage. And these people are willing to sacrifice a lot of time and effort, but nobody ever really gives them the opportunity to. Everybody says, you've got these changes, this is what's going on. Actually, you've seen your physio and they've given you a couple of band exercises to do and your shoulder hasn't got better and you're still getting pain on your serve, so we're going in to operate. Guys, I'm telling you right now, talk to these people, listen to them, and because they are, and they will be, in the coming 2 decades, a massive, massive group, a cohort coming through that we all see, and they all demand to be engaged with as athletes and not as some person in their 50s, 60s, 70s with a shoulder pain. And you do not get involved and chop things and do things, unless it's because that probably will stop them going out and playing their veteran county tennis, they'll be really unhappy. But instead what you do is say, look, if you really want to take this serious, then you see your very good physiotherapist 3 or 4 times a week for a period of time, and you get with a really good personal trainer, and you get way, way stronger than you are now, and you let go, and you have a little bit of a play around with the different rackets and the different strings and the different technology, and you see where that gets you, because that's going to get you a lot further than snipping somebody's long-headed biceps.
It's very interesting, actually, to see how many patients who present with shoulder pain can't stand on one leg.
Yeah, exactly.
They can topple over.
Absolutely.
Certainly, if you go to the States, where I think obviously baseball is a much more dominant thing, I think their discussion would be slightly different. They're so reluctant to do fixed slap tears now. They know that's going to be the end of their pitching career in reality. And so they're really moving to tenodesis. But I think it's obviously a different action. But I've got a question, actually, that was really for Monica and Susan. Once again, the shoulder, I'm a shoulder surgeon. A lot of these guys have been abusing their shoulders, and even at a young age. So when you do your diagnostic arthroscopy, you do your MR scan, you do see some labral pathology, but often there'll be something going on the undersurface of the cuff, the biceps, the pulley might be a bit different, there'd be a subscapularis, a little sort of tear at the top, possibly something in the subacromial space. So we know there's a lot of concomitant pathology as well. Do you have a sort of algorithm of way of maybe teasing out which bit might really be causing the problem? And do you have any concerns that fixing one before the other might cause a problem? Because a lot of the time it's not, for very young guys you may get one thing, but a lot of the time there's some other bits going on.
Yeah. So, I mean, yes, I absolutely agree with you. There's typically, if it fits perfectly posterior superior impingement and it's a clinical history and it fits that beautiful constellation of symptoms, that's perfect. But that's not reality, actually. And so your report ends up listing lots and lots of different things that you're seeing on the MR. But again, We want to be clinical radiologists. It's all about discussion with your clinician. That's why we have shoulder MDTs, where we actually discuss the case, what's actually pertinent, what's actually the problem here, does it fit the clinical picture? Because you're right, we could just be sort of technicians randomly listing all the abnormalities, and you do often see quite a lot of abnormalities, but I mean, sometimes we see quite a lot of AC joint degenerative change. No, not symptomatic at all. That's normal. So you're absolutely right. But I think that's the key, is clinician radiological dialogue, actually, to see if it actually fits the symptoms. Yeah.
Okay.
Susan, when you're operating, when you're operating and you do see a bunch of things, do you have a sort of thought? Would you ever fix both things at the same? Would you ever fix both things at the same time, or would you sort of?
Well, yeah, no, that's a good question. I think, firstly, it's what one surgeon would call a slap may not necessarily be what another person would call a slap. So you have to be fairly confident of that diagnosis. And type 1 changes, I think Monica said, the older you get, you see quite commonly. I wouldn't be rushing in to fix those. I would want to know that they had exhausted. I'm a big fan of therapy. If I know that they've exhausted and it's the physio who I know and they've been through a thorough program, then I'd be more inclined to offer fixation of the type 2. With regards to the rotator cuff, that scuffing, I wouldn't be in a rush to go in and fix that, because I don't often see the full thickness tears. If it's a full thickness tear, then I would probably do a biceps tenodesis in that case and fix the tendon, because long term it's that rotator cuff tendon that's going to give you a function for activities of daily living, as well as for the sport. So if it's a type 2, they've been through their rehab, in a younger patient I would fix it. If it's a type 2, it's an older patient, if they say I definitely want it fixed and I'm prepared to go through the rehab, then I will fix it. If it's an older patient who says, I actually just want one operation that's going to fix it for sure, then offer them the tenodesis. But the cuff I would probably leave alone and get them through to a proper cuff strengthening, scapular strengthening program.
And decompression?
Oh yeah, so the decompression, well, everybody needs a decompression, right? So, again, if there's evidence of bursitis when you look at the subacromial space, then I would probably offer speak to the patient about it beforehand, but do a soft tissue bursectomy. I wouldn't do an extensive acromioplasty, but if there was evidence. If it was pristine, leave it alone. Yeah. If it ain't broke, don't fix it.
So we have a couple of minutes left. I've got a question for Sam as well, because we need to go back to the elbow, but we'll have a question from the floor.
Tristan Fraser, medical student and recent abuser of my shoulders, the last gentleman put it. So I have a question, I think it's been touched on just now. So these athletes are starting younger and younger in really intensive training programs. Would it ever be worth sort of scanning them, having an evaluation before they get to that stage of injury? Because, so from listening about the different types of tennis techniques and that, so seeing if the person can take that stroke or whatever before you get to 10, 15 years down the line and they're in that position where they're having to take time out and affecting their career. So adapting their
some sort of screening
to their
process.
anatomy, screening process.
Well, actually, that leads quite nicely into the question I was going to ask Samuel, which was in relation to the elbow, where you see this valgus overload extension and the medial collateral insufficiency. You've elegantly described removing the osteophytes and the reconstruction, but is there a role for screening, for trying to identify players at risk, and are there other interventions that you can adapt that will prevent the elbow from breaking down, the wrist from breaking down, kind of in advance of when they come to the clinic?
Yeah, so I guess if you could do that, you would be rich. Because, but there are factors that you can anticipate that may cause problems. Laxity is a problem in any of the joints we have. In an athlete, if you have a lax elbow, a lax shoulder, lax elbow, lax shoulder, lax wrist, they have a higher chance of developing problems. So, but how can you correct laxity? It's impossible. You can just have endurance in your muscles. You can encourage proprioception and let the athlete know which is the limit where they can go. But laxity cannot be corrected. So, to answer the question short is, yes, you can identify patients who are at risk. You can tell them that they have to maybe modify their way of throwing or doing the slap and the tennis. But if they develop the symptoms, those patients should be treated before, at least in the elbow, they develop the degenerative changes. So if they have cartilage injury, if they have laxity, that needs to be treated with rest, modification of the movement whatsoever.
Yeah, I'm James Brown. I'm Doctor for British Athletics. It's not really a question. It's a bit of a summing up thing. I think the guy on the end there's got everything down to a T. We're trying to fix a problem. Even if it's a young athlete, we're trying to kind of say, okay, you've got a bad wrist, we're going to modify your technique, we're going to try and fix it. But if we talk to these kids who want to be like their elders, they want to be like Federer or they want to be like Nadal, what's happened to those guys is they do strength and conditioning. That's how tennis has changed. That's how sport is changing. It's strength and conditioning. So your patient that you see in the 40s and the 50s who wants to carry on playing tennis till they're 85, the best thing you can do for these people is to say, go away and find a good strength and conditioner, because you'll find much more benefit over a long period of time than coming and seeing me and having an injection. And I've done thousands of injections, or send them off to a surgeon. I think that we have to really think the guy in the end's got it down to a T. It's really about getting strong, and that's it.
Well, I did a little calculation a few years ago for some GPs that I was talking to. And if you play tennis, if you start at 15 and you play till you're 65 and you play once a week, 3-set match, you win every point and every serve goes in, you'll serve the ball 93,000 times and you'll return the serve on average about 150,000 times. And if we assume that lifting your arm is half your body weight and probably double the force when you actually hit a ball, it comes to 7,000 tons that your shoulder experiences over the course of your tennis career. So it's a miracle that anyone survives that sort of abuse. Well, thank you very much for the faculty members and also for the very interactive discussion we've had. It's been really enlightening for me. I hope you've all enjoyed it and look forward to seeing you for the other sessions. Thank you very much.